Dr. Mukesh, we are live now.
1 minute, sir. Am I audible to you, sir?
Yeah, audible and visible. Please
Okay.
go ahead.
Yeah. Good morning, everyone, and I welcome you to the first session of this Type 1 Diabetes education program. And it is a wonderful opportunity for everyone, all the pediatricians, practitioners, residents, to learn more about type 1 diabetes. And it's an honor here to be with the esteemed faculty today, and I welcome Dr. Alok Bhandari, Dr. Ajay Gupta, Dr. Vipul Jain, Dr. Rajiv Singla, Dr. Sameer Agarwal, and esteemed faculty Dr. Nikhil Tandon, who is head of the department endocrinology at AIMS. And IIP is and Speed both are deeply committed to this diabetic education program, and we have formulated this online module, and we are going to uh, do it all across India. We are planning to do it all across India, and and uh, what went in our minds to start this diabetic education program. For that, I would invite Dr. Rajiv Singla, and Dr. Rajiv Singla is coordinator, the course coordinator. He has designed the course, and I welcome Dr. Rajiv Singla to explain more about how we are going to uh, plan this education program across nation, and please welcome Dr. Rajiv Singla. Dr. Rajiv, over to you.
Thank you. A very good morning to all of you. Thank you for the kind words, Dr. Mukesh. So first of all, my gratitude to entire IAP team, Dr. Alok Bhandari, Dr. Ajay Kumar Gupta, Dr. Vipul Jain, and Dr. Mukesh Verma for allowing us to conduct this course under IAP's shadow. And then the idea behind starting this course was, and I'll share a few slides with you regarding this course and how did we come across this idea was. So basically what we realized was that this type 1 diabetes, uh, although we see it all across the India, but uh, the education regarding this type 1 diabetes education was lacking in all across medical education that we had. And then I had a great experience at AIMS. I learned all these things from Dr. Tandon itself, who's our first speaker, and I'll introduce him at end of this. So we thought that we should try and perpetuate education regarding type 1 diabetes all across. And we've got this group which is called SPEED, which is Society for Promotion of Education in Endocrinology and Diabetes. And then it's a group of endocrinologists who are committed to perpetuate education. And the group is well known for SpeedCon conference that we do annually at Delhi, and now it's supposed to be one of the best endocrine conferences in India. As a part of type 1 diabetes education, we took a three-pronged state. First of all, we started off with a type 1 diabetes education initiative for caregivers, which included paramedical staff, the family members, and type 1 diabetes education patients per se. And now we are going off with our second leg of starting type 1 diabetes education for pediatricians, for physicians all across India. And then we also plan to start a specific module for schools. Just to tell you very briefly about the caregiver part has already taken off for last 2 years, and we include people from all across India. And then we've this caregiver program was designed again under a guidance of Dr. Nikhil Tandon and Dr. Yashdeep, and the entire speed team came together to create content for this type 1 diabetes education initiative. And then it included basically on the same format as we have today's the current program. Basically, initially 5 or 6 modules are core therapeutic modules, which talk about how to start insulin, what to think about insulin, what therapies to be designed for each individual person, and then how to go about diet, carb counting, and all those stuff. And then CGM, how to interpret those blood monitoring systems. And then finally, the allied questions regarding type 1 diabetes education. And then we are running into second year for type 1 diabetes education for caregivers. In 2023, we trained almost 500 trainees across 34 centers pan India. And this year we've enrolled more than 800, almost 1,000 enrollees this year. And then we've spread to 57 centers all across India, which is being run by endocrinologists and people who are caring for people with type 1 diabetes all across India. And then schools, we are just in a pilot phase at the moment, and then we hope to escalate in this in coming years. Which brings me to the last thing today, that this course basically is a collaboration between IAP and SPEED, and we have tried to cover all the aspects of type 1 diabetes care which you would see in your clinics. We would try to keep all the information very, very practical, trying to not go into theoretical aspects. Apart from the course live lectures, we are also trying to give you some video sessions which would be designed again by the esteemed faculty all across India, and which would be shared in the groups, and then you can look at those sessions at your own leisure. Of course, after each session and after the completion of entire course, your feedback is requested and would be greatly appreciated, because we want to run this course over time all across the India. So that was regarding the course, and now my job is to introduce today's speaker.
Sir, I would, Dr. Rajiv, I would take a minute of yours. I would also like to acknowledge the presence of Dr. Alok Bhandari, who is President of Indian Academy of Pediatrics, Delhi. And I would request Dr. Bhandari to just give a brief message to all the participant and esteemed faculty. Dr. Bhandari, sir.
Well, good morning, friends. Dr. Nikhil, sir, sorry, but Dr. Mukesh has thought कि आपका introduction और अच्छे से और बड़े तब तक और लोग join कर लेंगे. We are, as you know, sir, Indian Academy of Pediatrics is the largest professional association of doctors in India. We have a strength of more than 45,000 across country. We have 31 state branches and around 350 district and city branches. So our members are spread all across the country, and all are as an Indian Academy of Pediatrics is known for academics. So we are very much into it. And when this idea, and when we shared with dear friends Rajiv and Samir, it was immediately taken up as an excellent idea, and we'll further expand our ideas. And Delhi, why Delhi out of India IAP? Because Delhi Hindustan ka bhi dil hai, and we are the academic capital of IAP also. We have 38 institutions in Delhi who impart postgraduate teaching in pediatrics. So all those 38 academic centers of excellence in Delhi are available to the SPEED team for collaboration, and we'll take it forward to other support groups also. And abhi to shuruaat hai, aage aur badhayenge. Welcome, sir. Welcome. Good morning and happy Makar Sankranti to all.
Thank you. It's my honor now to introduce Professor Nikhil Tandon. Professor Nikhil Tandon is Padma Shri, awarded Padma Shri. He is head of endocrinology at All India Institute of Medical Sciences, Delhi. Torchbearer of type 1 diabetes care in India. He is in charge and nodal center of ICMR Diabetes of Young Registry. He has innumerable publication and awards to his credit, and he is excellent pillar of support of type 1 diabetes initiative and SPEED. Over to you, sir, Professor Nikhil Tandon, sir.
Thank you so much. If I'm permitted to share my slides, I will try and do that. First, let me say that, IAP is the largest association, and I think endocrinology is perhaps the smallest association of doctors in India. So it's a bit of a mismatch in terms of हम बहुत छोटे हैं आप लोग के मुकाबले में, but we sort of look at an area which has common interest, and we thought that it would be important for us to give our perspective and our viewpoint, especially because the largest bulk of people with type 1 diabetes will go to a pediatrician, and it's as simple as that. And therefore, any sort of uh, coordination which can be done between pediatricians, pediatric endocrinologists, and adult endocrinologists will always be good for the patient, and that is what we are all sitting here for. So let me now try. Dr. Vipul had taught me yesterday how to do this. Let me try and get my slides in place. Always a moment of anxiety before it happens, but let's see. सब ठीक होगा. Right. Can I just get confirmation कि slides दिख रहे हैं?
It's
Yes,
perfect.
sir.
Perfect, sir.
Perfect, sir. दिख रहा है.
Thank you. So I know Rajiv mentioned that we will not be theoretical. Today's talk, however, will be a little bit more theoretical, a little less practical, because it's not so much as a knowledge-based talk. It's basically to sensitize a large group of pediatric colleagues about this particular area. And having seen it's a very well curated program put together by IAP and SPEED together. And the specific basic aspects will be taken care of in the subsequent modules. But I just want to share and get your guidance, your feedback to some of the issues which we as adult endocrinologists end up seeing. And I hope that, it's a mutually relevant learning experience. Okay, let's see if I can. Okay. So I'm going to start with a case vignette, and it's a depressing case vignette, but I think it's not an uncommon case vignette. And I think it's important for me to give you the journey of a real patient and a journey which was not a very successful journey. So this is a female type 1 diabetes patient who was actually born on 14th of November. Some of you may know that 14th of November is actually the World Diabetes Day. She was born on the 14th World Diabetes Day of 1988, was diagnosed at the age of 6 years, was being treated, in the vicinity of her residence. She came to us at AIMS about 10 years after she developed diabetes, and she was registered in what is called the Diabetes of Young Clinic at AIMS. She had a paternal history of type 2 diabetes. Unfortunately, she also had celiac disease. So important point out here is that the prevalence of celiac disease in people with type 1 diabetes is much more than what happens in the background population. So it's an important thing to keep in mind, and maybe every few years a test for IgA-TTG would be useful because it adds to the complexity of dietary management. There was also a delay in onset of puberty. This is her hemoglobin A1C from the time she came to us. I'm not even commenting on the period when she was being treated elsewhere. As you can see, we did not do a good job at all. Let's be very honest. And I think it's always good to accept our limitations, our frailties, our deficiencies, because unless we recognize and fix those, our patients suffer. As you can see, it remained somewhere between 8 and 10% virtually the entire period of about 10 years, so which I have a charting out here. I'll come back to this charting a little later in the course of this talk, but as you can see, not well managed at all. And this is her clinical evolution. Diagnosed, registered at AIMS. By the time she came to us, she already had albuminuria. So she already had developed nephropathy. Now, the point I want to raise is, and this is not in any way, a negative comment, that most pediatricians who are looking after people with type 1 diabetes will not have the bad fortune of seeing development of complications. Unfortunately, the period the child spends in the company of a pediatric specialist is a period of time when the complications have not emerged. We have the misfortune of actually seeing those and managing those as adult endocrinologists. And sometimes what happens is, because if I don't see complications as a treating pediatrician, I perhaps, switch off from that totally because I don't see it on regular practice. In our case, it is a big problem. As you can see, the patient, by the time they came to us as a, adolescent, or they already had nephropathy. Hypertension 3 years later, which obviously means at this point of time, the chronic kidney disease had set in. Dialysis had to be started in 2011. So you can imagine within 15 years of disease onset, this child was on dialysis. Proliferative retinopathy in 2012 requiring infections. Dialysis was given at a place where possibly all the precautions were not taken. So she had developed both Hep B and Hep C infections. Now, please also understand the implications of that. If you have hepatitis, and you want the patient to go for a transplant, you have to clear the virus, because otherwise, if you give immunosuppressants after the transplant, that hepatitis is going to flare up and create another set of problems. So, the disease becomes increasingly complex. And unfortunately, we lost this patient 10 years ago because of chronic kidney disease. So you can see this is a terrible journey. ये rural patient नहीं है, ये tier 3 city का patient नहीं है, ये दिल्ली का patient है, right? Start to end, an 18-year-old journey in which we lost this patient. And she was out of those, she was being treated by us for 10 years. So clearly, we're not doing something properly. This is just, from our own follow-up at the Diabetes of Young Clinic. I just pulled out all the patients from whom we had mortality information. And as you can see, people have died as young as 7 years of age. But the oldest person who's died in our cohort was just about 50 years of age. Assuming that life expectancy at birth is 70 in India now, 68, 69, 70 years. Look at the number of years of life lost, which is happening in patients who are born and brought up in Delhi and being treated in Delhi. So I'm more or less sure that, the situation is as bad, if not worse, in other metropolitan cities, and definitely even worse than this in smaller towns and in rural areas. That's a huge number of years lost. And this is when we are aware of the disease, we know how it is to be treated, and we are still not doing a very good job. And I'm saying we because, all these deaths are happening on my watch. So a couple of small studies on mortality. This is from Sanjay Gandhi PGI. This was a small study which looked at a total of about 2,500 patient years of follow-up, which was, maybe about 200 odd patients followed up for about 10 years. And the median duration of diabetes at death was under 10 years, right? Major causes of death, please remember two important causes, so one of those causes is virtually never seen in the developed world today, which is diabetic chronic kidney disease, because A, it doesn't happen. B, when it happens, they are managed with renal replacement therapy. And the others were infections and DKA. This is a communication which I received on request from Dr. Madhu from UCMS, who also looked at the causes of death in 58 of his patients. Again, you can see CKD 13 and DK and or uncontrolled hyperglycemia another 24. So, again, people dying of DK and this is not DK at presentation, which is a different story. You didn't know somebody had type 1 diabetes, they developed DK at presentation. The diagnosis is delayed or missed and they die. That's one story. These are patients who were registered in a clinic. So they already knew they had type 1 diabetes, despite which, because of perhaps weakness in our education, weakness in their ability to manage limited resources, they still died. Now, that is terrible. So if you're looking at diabetic ketoacidosis and mortality, the burden is very high, especially amongst low-income countries, right? It varies from under 0.5% in developed countries to as much as, 10 to 15% in developing countries. The occurrence of cerebral edema, which is invariably seen in pediatric patients, so is very relevant to the group of pediatricians who are attending this call, is as low as 0 to 5% in high-income countries and is as high as about 1 in 4 in low-income countries. Now, clearly, our resources, our ability to diagnose, our management protocols require a lot of sort of improvement, because otherwise, we are allowing known patients of diabetes to develop diabetic ketoacidosis, and these patients are not surviving. Children from low-income countries presenting with renal failure and DK is not uncommon, again suggesting that vascular complications are happening because of our ability to manage sugars tightly. And delay in diagnosis and misdiagnosis leading to DK and death are very common in low-income countries. So this is just to give you, this is a slightly different story. This is prevalence of DK at type 1 diagnosis, right? So, you can say, well, हमें तो मालूम ही नहीं था बच्चे को type 1 diabetes है, जब present किया तो वो DK के साथ present किया. So this is, lowest is in the, the Scandinavian countries, which have an exceptional healthcare system, 15%, 18%. And highest even in other countries in Europe, it goes as high as 35 to 40%. But overall, this is about 30% of people with type 1 diabetes are presenting with diabetic ketoacidosis. ठीक है, उसका हम कुछ नहीं कर सकते, बिल्कुल कर सकते हैं. हम ये कर सकते हैं that our index of suspicion कि कोई भी बच्चा इमरजेंसी में आए किसी भी परेशानी के साथ, उसका हम एक बारी शुगर तो नाप लें, क्योंकि कई बारी वो पेट के दर्द के साथ आ रहा है, उल्टी के साथ आ रहा है. Nobody is really thinking of diabetes at that point in time. It suddenly comes out of the blue. Patients often are no position to give a history. Parents often forget कि हाँ 3-4 महीने से लगता है बच्चा पतला तो हो रहा है, लेकिन हमने सोचा कुछ ऐसे ही चल रहा होगा. This is an interesting study, which, and I'll talk to you more about this. So we run a registry, which is I'm going to give you details of that. We looked at the data of our registry and harmonize it with the world's biggest registry, which comes from the US, which is called Search for Diabetes in Youth. And I'm not going to go into details, except to say that interestingly, that we have a very similar, if not lower prevalence of DK compared to US. I think this is a data artifact more than reality. The fact is that these are people who have survived that DK and then being taken into the healthcare system. That's why they are part of a registry. The fact that there is a lower prevalence here also perhaps for me indicates that a lot of these children had DK, died, and therefore they never entered into the health system for chronic care of type 1 diabetes, a matter of significant concern once again. So what are the factors associated with DK diagnosis? These are on this slide are factors on which you and I as doctors may not have too much control, but nonetheless, it's worth knowing about it as a red flag. Younger children have a much higher likelihood of DK diagnosis. It's important to understand the younger the child, it's very often they have more severe beta cell dysfunction, much more likelihood of having undetectable or absent C-peptides, and therefore they have more severe disease. There is slight excess in girls. There is if there is a first degree relative with type 1 diabetes, it decreases the frequency of DK for the simple reason that you have at the back of your mind, there is already an understanding what diabetes is like, and therefore patients are often taken by their parents earlier for medical attention. It's a higher frequency amongst those with lower BMI, again suggesting that they have had, uncontrolled hyperglycemia, osmotic symptoms, loss of weight, but that was not picked up either by the family or by the treating physician, and therefore they had more advanced disease by the time they presented with DK. And this is again something which we can't do about a high DK among children of consanguineous parents. Children with DK had a shorter duration of symptoms on many occasions, very often had a preceding infection or febrile illness which precipitated it, had again a high background prevalence of diabetes in the country or in that society leads to a decreased risk because it is recognized early by the system, right? So these are certain factors over which you and I may or may not really have much by way of control. But there are physician factors. And I wanted to highlight these physician factors because you and I can actually do more. A delay in the diagnosis. And these are studies not from India. They're happening in developed countries. A delay of more than 24 hours between the initial presentation to a primary or a secondary provider referral increase the risk of DK. So a child was brought to a doctor, but that he or she is not well. The failure to consider type 1 diabetes as a contributing factor or the real reason for that state of ill health leading to a delay in diagnosis contributed to a risk for decay. And the second thing were children who were not diagnosed in their first visit. Again, because it was not thought of. It's very simple to diagnose. A finger prick, capillary blood glucose is going to take care of it. But that was never really thought of. So this again leads to a significantly higher risk. Similarly, children who presented with decay had many more medical consultations. Again, the same reason. They had the consultations, but people did not think. So I'm just flagging this for the pediatric community at large. I know it's a relatively rare disease, but please do keep it at the back of your mind whenever you have a sick child that there could be either type 1 diabetes as a primary reason or type 1 diabetes contributing to the overall spectrum out there. And an early diagnosis and an early protocol-based intervention would be ideal. So I'm not going to talk more about decay now. There'll be a specific module which will take care of it. I'm now going to take you through the registry. And it's to give you a little sense of India's data. And then I'll move to another part, which I am extremely, extremely sort of concerned about, is the fact that our ability to establish good follow-up of our patients is leading to two problems. Poor management, because patients don't come periodically enough for us to make changes in their treatment or recognize their complications. And the second part, of course, is that in the absence of this follow-up, we also don't recognize the problems that are happening. So we feel that the children are doing well because they haven't turned up, but the reality is they may not have been doing well at all. So this is a registry, which pretty long name is called the Registry of People with Diabetes in India with Young Age at Onset. And we call it YDR for the rest of this talk. It's a study by the Indian Council of Medical Research. And essentially, the principle behind the study was that we will start with certain metropolitan or larger cities, right? And we will identify one or two sort of collaborating centers within the city. So like Delhi and Mumbai being larger cities have two collaborating centers. Then we will recognize or identify physicians and pediatricians who have a special interest in looking after people with type 1 diabetes. And it's a lot of this was by word of mouth, and there was no sort of fixed criteria that if they're not registered, if they don't become a reporting center early in the registry, anybody can join at later points in time. But by and large, we said that we will look at sites which have about at least 10 new patients of type 1 diabetes on an annual basis, so that they have a significant number which can contribute. So this is the structure, reporting centers where patients are being seen, and that's the site of data collection. The collaborating center in that city really takes the data from all these reporting centers and puts it together. And then comes to the technical coordinating unit. So AIMS can actually have multiple roles. I see patients, so I'm a reporting center, the Diabetes of Young Clinic. But we are also one of the two collaborating centers for Delhi, along with Dr. Madhu from the UCMS. So about 25, 30 reporting centers we collect the data from and collate. And then we are the National Technical Coordinating Unit. So I get data from all across India, which puts me in a position to be able to share this information with you. Now, please remember that this is a large study. I mean, we have recruited from 2000 till now just under 25,000 individuals with youth onset diabetes, which makes it perhaps the largest national registry of young onset diabetes anywhere in the world. At the moment, we have 11 regional collaborating centers and 200 reporting centers, so about 20 reporting centers per collaborating center. We have listed 10 possible variants of diabetes, the dominant, of course, being type 1 and type 2, and I'll come to the type 2 part in a second, and then we won't talk of type 2 after that. But these are all clinical diagnoses. So we've said a person who comes in young age of onset, acute presentation, or requiring insulin within the first 3 to 6 months of diagnosis is somebody with type 1 diabetes, right? So we've not used, because to make it simpler to recruit these people, we have not really taken into, antibodies, etc., which makes it more difficult, but I'll still give you some information on that. We also have follow-up data, which is, I'm sorry to say, not the greatest quality of follow-up data, but we have follow-up data for 22 years for different number of people for different lengths of time, which allows me to share certain observations with you, which I think are very important for us. So I've already mentioned about this. We started with 8 collaborating centers, have become 11. We're about 200 odd reporting centers, which are the sources of data collection. And essentially, when we started, it started in 2006. We allowed centers to go back in time. So there was some retrospective component, but the basic premise is when you enter into a reporting center, we do a baseline pro forma. And then every year, so let's say somebody got recruited into or registered in a reporting center. First, let's say went and saw Dr. Rajiv Singla in 2012. That's the baseline pro forma. The time they come in 2013, we'll do a follow-up pro forma. So baseline and an annual follow-up pro forma. Now, the criteria was, and we can have an argument about this, but that the age of onset, we called it youth onset diabetes. People said you should have done less than 20 years. We did less than 25 years because most studies of adult diabetes in India at that time were 25 years and above. So we said otherwise those between 20 and 25 will get lost. So age at onset of diagnosis should have been less than 25 years, and they should have been registered in a reporting center on or after 1st of January 2000. So in my DOY clinic, there are patients who have registered in 1995. We don't include them in the registry because they came to us even before the cutoff date of 2000. The third thing is that they have to come from an assigned geographical area, right? So lots of us in Delhi see patients who come from outside Delhi NCR. Because Delhi being a big city, we don't include that because otherwise it becomes a problem for us to establish a denominator that, in a defined geographical area, if you're looking at a population-based denominator, it becomes impossible for us to do that. So that's the third thing which we've done. I've already told you about the story of reporting center, collaborating center, and the national technical one. Now, we, as I said, have about 25,000 people. This is a slightly smaller group which I am presenting to you out here. I'm not sure if I'm the lower part of my slide may not be visible. But anyway, so the first thing I must say is that about 60% of all the data is actually coming between Delhi and Chennai because we had aggressive physicians who were really recruiting it. But nonetheless, we have a reasonable contribution even from the Northeast, from Kashmir, and from other parts of the country. So there is reasonable data which we have from different parts. The first thing that you have to understand, and I'll break this into 2 parts, for the whole study, that those under 25 years of age, 2/3 are type 1, 1/4 is type 2. Now, not many of you are old like me. When I was an undergraduate, and if I saw a 20-year-old patient with diabetes and I made a diagnosis of type 2 diabetes, I would not have passed the examination. I would have been told, aap 6 mahine baad mein aao, right? For the very simple reason that we didn't see type 2 diabetes at, that age group. It's important for pediatricians to now realize that type 2 diabetes in the young is an emerging specialty. Again, I will not talk about this in this talk, but please remember, it is a different sort of disease from adult onset type 2 diabetes. It is a much more aggressive disease. There is much lower beta cell function. There is much more requirement of insulin. And the prevalence and incidence of complications in youth onset type 2 diabetes is actually even more than youth onset type 1 diabetes. So it's a very, very different sort of disease. And therefore, the tendency for all of us that, oh, this is all right, this person is okay, we can manage this person with tablets, and therefore this is milder disease, is not really correct. The other thing which is important for us to note is that there is some regional variation. That in Delhi, for example, 80 to 85% of all patients were type 1 diabetes, whereas in some places like the Northeast, like Assam, in Manipur, And for that matter, in Chennai also, there was a much higher contribution of type 2 diabetes. Now, this could be a reality, or this could also reflect the sort of physicians and pediatricians who are participating in the study. And therefore, you may get a skewed sort of distribution between type 1 and type 2. But remember, I'm saying all this because type 2 in the young is a reality which we cannot afford to forget. And in this, you can say that even if you remove the 20 to 25 years age group, which doesn't fall under the purview of pediatricians, even in those who are diagnosed less than 20 years of age, and this is what I've written in the yellow box out there, 10% of anybody who's diagnosed with diabetes before the age of 20 years, which is the age group seen by pediatrics, 10% had type 2 diabetes. So this is important because this was something which we did not recognize or really think of in, maybe let's say 20 years ago. It's now become very, very obvious, and this has to be looked at with much more care. And this is an important point I wanted to communicate. What about hospitalization? Now, these are data from the registry at baseline, right? So when the person has come to a reporting center, we fill a baseline pro forma, we ask, have you ever had hospitalization for your disease? Please see that about 1/4 already had DK or severe hyperglycemia and already had a hospitalization. Now, that is very important because and these are then patients who have now entered in the system, but even before they saw a specialist interested in type 1 diabetes, they already had an episode of DK. And this is again reinforcing what I said earlier. And of course, there may be some more unfortunate children who may have had DK, but did not survive that episode of DK. So the key findings from the Young Diabetes Registry was that for type 1 diabetes, the mean age at diagnosis was about 12 years. So, around the sort of early second decade is what happens. For type 2 diabetes is obviously much older. And you will see that for type 2 diabetes, this is very, very rare to see it in the first decade, at least currently. And most of the cases start coming around the time of puberty or later. So even in the second decade, the bulk of these cases of type 2 will come in the second half of the second decade, that is between 15 and 20 years. And then, of course, there's a surge after 20 years. The second thing which is important for us to understand is that about 50% of patients with type 1 diabetes actually reached a specialist within 6 months of symptom onset. So that's not really too bad. That means they are fine. And this is Delhi. It may not be true for other cities. The most common mode of presentation amongst patients with type 1 diabetes was a combination of osmotic symptoms and weight loss. But if it's taking 6 months for them to reach attention, that means people did not recognize that osmotic symptoms or weight loss are because, people don't think of diabetes at all at that age group. Often people think, child may not be eating well, child may have some infections. I'm just requesting you once again that for the sake of early diagnosis and prevention of DK being an event at the diagnostic event, please try and keep diabetes at the back of your mind. The other part, now, obviously patients, this is again baseline data. So patients may have been registered up to 3, 4, 5, 6 years later in the specialist centers. But 15% of all patients and about 10 to 12% of type 1 diabetes already had one chronic vascular complication of registration. And please understand the important part of this statement is that vascular complications are irreversible today. The best we can do is if somebody has retinopathy or early albuminuria is to try and prevent progression or delay progression, but we cannot reverse with the known treatment. So that is again, so this has to be our goal, prevention of DK, so early recognition of symptoms, good management so that once people are diagnosed with type 1 diabetes, they should never have DK. I mean, the goal of any type 1 diabetes clinic is that there should be 0% DK in a person who's registered with a pediatrician or a physician and is known to have type 1 diabetes. A patient who is registered in your clinic with type 1 diabetes and has DK is a marker of failure of care. And that has to be, and I'm not saying it doesn't happen with our treatment, it happens, but we have to say that this was our failure. And we cannot have, so it has to be you normally use the word zero tolerance. So zero tolerance to decay in a diabetes patient who's already been diagnosed. The other thing is you must remember that these patients also are very likely to have other comorbidities. So it's an autoimmune disease. It can have associated autoimmune hypothyroidism, celiac disease. Again, at the back of the mind, you must really keep that when you're following up patients. Now, follow-up is something which is critical because I'm going to show you, and I'm showing our data. So I'm not sort of pointing fingers at anybody else when I show you. I'm pointing fingers to myself and our clinic and showing you our deficiencies and our limitations. I'm not proud of it, but then I don't want to hide it under the carpet because unless I recognize and acknowledge it, I will not do anything to improve. And what we have learned is that we have terrible follow-up. There is no other polite, diplomatic way of actually saying this. This is the story from the Diabetes of Young Clinic at AIIMS in 2021 November, so about 2 years ago, the story of loss to follow-up. It's an absolutely depressing story. At that time, we had about 1,400 patients registered in the Young Diabetes Clinic, of which records were available for 1321. Files had gone missing in 47. We're a Sarkari Aspatal, we are paper. So, missing files. But after that, we have not lost a single file because it is, there's death penalty if a file is removed or lost. There is no other, the identified human being is summarily dismissed. There is no question of losing a file. Now so there's this study, the clinic started in the late 1980s, early 1990s. So everybody didn't even have phone numbers, right? There were only landline numbers. So phone numbers were available in only 780 of these, of which only 400 were on regular follow-up. So if you actually look at that, out of 1,400, only 400 were on regular follow-up. And we defined regular follow-up that they should have made at least one visit in the last year or so, right? Now, of those who had the phone numbers, you can see that about 770 had phone numbers. Call was not picked in 42. They were not reachable in 7, phone switched off in 7, invalid number in 135, wrong number in 28. So, there was, even when you had the phone number, there were problems. So my request is when a patient comes to you, please have all the details. Now we've started keeping 2 phone numbers, 2 email addresses and addresses because landline numbers hardly change, mobile numbers keep changing, and it's much better to have more information. I'll tell you the reason why I'm saying all this. So then we did a little study to see the frequency of care and control of glucose in a clinic population with type 1 diabetes. And we essentially said that the international guidelines say people with type 1 diabetes should visit the clinic 2 to 4 times a year. And at AIIMS, we recommend 4 times a year with an HbA1c in each. So we looked at all patients who attended our yearly screenings and who attended the clinic at least once between 2013 and 2016, right? Number one, let me point out the mean HbA1c is something which is shocking and it is nothing to be proud of. And it was 9%, right? It is really a terrible A1C. This is about a percentage point better than the national type 1 diabetes average A1C from the registry. So we're really not doing a good job, number one. Number two, the mean clinic frequency in 2016 was about 2 as opposed to 4, which was recommended. And in the 3 years between 2016 and 18, when we expect 12 visits based on 4 visits every year, the mean was about 7. So again, people were not coming as regularly as we wanted them. But look at, just to give you a little sense, this is not dramatic data, but if you look at the mean HbA1c in 2018, based on the number of clinic visits in the preceding 3 years, the more the number of clinic visits, you had a lower A1C, and it was about 0.5, 0.6% lower. Now, that may sound very little, but remember, in studies like the UKPDS or the DCCT, the difference between the control arm and the intensive arm was just 0.9% or 0.7% in one instance. So, 0.6, 0.7% is not as, as insignificant as it appears when you look at it. The second thing, the prevalence of poor glycemic control, which we defined as people with an A1C was of more than 9%, was about 20% higher in those who had a single visit compared to those who had between 2 and 4 visits. So clearly, if patients can be encouraged to come on a regular basis, you will improve their control. And that is the other message which I want to give. Please ensure. Now, I know my friends in the private sector tell me, sir, you in government sector can phone up the patient. When our staff phones up a patient, the concern is that are we calling them to the clinic because we want, to get our consultation fees out of them, and are we troubling them unnecessarily? And I understand that. So I'm not sort of being judgmental, but find your own ways to ensure a frequent enough follow-up. I always thought that we were doing a bad job because, we cater to a low socioeconomic, relatively undereducated population. But you'll be surprised to know that in the Young Diabetes Registry, AIMS Diabetes of Young Clinic has the best follow-up rate of 203 reporting centers across the country. We are Sarkari, our patients are poor, our patients have poor education, and we have paper records. And we've managed it because we thought it was important, and we keep on at it. So once you have a patient, the problem is that we only do chronic care. Pediatricians also do acute finite care. So sometimes it's very difficult to reconcile the strategies for acute finite care with strategies for chronic care. Now, somebody who comes to you with an acute febrile illness, it's acute finite care. The way you handle that patient and the way you handle childhood asthma, childhood epilepsy, cystic fibrosis, type 1 diabetes is very, very different. And sometimes we don't apply our different strategies for these different scenarios, and therefore the follow-up also becomes less. So to improve follow-up, what we did, and I'm just giving you our own example, I won't spend too much time on this, but again, different clinics can do differently. We decided that patients are not coming, let's at least try and get them once a year if they're not coming, and at least get their annual workup done. So we started organizing a Diabetes of the Young Day camp at AIMS. Within AIMS, we did it till COVID came in, and we haven't been able to restart, but now we have other mechanisms of ensuring. So we used to call all our patients with type 1 diabetes on one day. They used to come fasting, they got registered, we took their blood sample, we created a facility for them to give insulin. We provided them breakfast. They came back for the other evaluation, including fundus, including neuropathy assessment. They underwent diabetes education. They underwent dietary counseling. And then they had lunch and they went back home. 2019 was was lower than 2018. 2018, we had 449 people with type 1 diabetes in that camp, which I don't think anywhere in the world you would have had 449 people in one roof. The reason why it was less in 2019 is because that morning in Delhi, the temperature was 1.6 degrees Celsius. Despite that temperature, we had just under 400 people who came, and the patients asked us, ki, sir, camp kab karenge hum? Now, we've stopped doing that, but this has improved our follow-up because now they recognize the reason why we did the camp and recognize why it should be done. Now, I brought the camp in because this allowed us to screen for prevalence and incidence of vascular complications. The point I want to raise here is twofold. That there is already a prevalence happening even in anybody who's had 5 years of type 1 diabetes. So that's the time when you really start. So anybody who's more than 10 years of age and has had more than 5 years of type 1 diabetes must undergo screening for vascular complications. The terrifying part of the story here is not part of today's lecture, but I again wanted to flag it. Why I've been talking a little bit about type 2 diabetes is that the prevalence of vascular complications in type 2 diabetes of the young, after adjusting for everything else, was 2 to 3-fold higher. So clearly, type 2 diabetes in the young is a very different and aggressive disease. So again, my request to practicing pediatricians is that just because you have an obese child who you think is enough to be controlled on metformin because they have type 2 diabetes, please don't sort of de-emphasize the importance of the disease as compared to your type 1 diabetes patient. So that's the first point in the complication story. We then looked at incidence of complications, and again, the same thing came out, that the incidence of complications in youth onset type 2 diabetes was about 3-fold higher than that in type 1 diabetes. I'm not saying it doesn't happen. Obviously, it happens in type 1 diabetes, and it happens as you go ahead with duration of exposure. And obviously, the duration of exposure is likely to be more, and I'm going to show you data on the next slide. Now, this is the age-adjusted incidence rate of microvascular complications. And if you just look at the left-hand side of the slide, you'll see that as you go in duration from more than 5 years to more than 15 years, it climbs up. Nephropathy climbs up, neuropathy climbs up. And again, the same thing happens with adjustment. If you look at type 2 diabetes for similar durations, it has 2 to 2.5 times higher incidence again. So remember, we must look at, unless there is follow-up, you will not do vascular complication screening. Unless there is follow-up, you will not titrate their doses. You will not achieve good glycemic control. I'm very happy to say that from 400 people who are regularly under follow-up, when we did the study in 2000 and whatever it was, we have now, because of all the camps, because of our obsession, the number of follow-ups has increased. Now 600 people are on regular follow-up. That's a 50% improvement on follow-up. I'm now sort of coming towards the end of my talk, but I just wanted to bring in a small thing about antibodies. Samir, in the next session, is going to talk to you about that all youth onset diabetes is not type 1 diabetes, and sometimes you really get stuck. Is this type 1? Is this type 2? Is it a lean type 2? Is this an obese type 1? Is this a monogenic diabetes? So one of the things which is often done is looking at antibodies. Now, antibodies may or may not be available in everybody. And I say, if a young, lean patient who's presenting with diabetic ketoacidosis, clinically, they're so clearly type 1 diabetes, I don't see the big advantage of actually doing an antibody, especially if the patient has to incur costs. We don't allow patients to incur costs. We try and generate money from here and then do our own tests ourselves. So this was a study in which we looked at prevalence and persistence of antibodies in the AIMS DOY clinic. So the median duration of this cohort this is just more than 350 patients. So again, it's a fairly large single center study. Interestingly, that even at a median duration of 6 years, 2/3 of the patient had some antibody positivity. Right? So, aisa nahi hai ki with a period of time, there is a sharp decline, there is a persistence of antibodies, right? That increases if you take somebody who is less than 2 years of disease duration. That's a little bit more than 70%. The second point I want to raise, there is pressure now. There are new antibodies. You can do IA2, you can do zinc transporter 8. But here, just to give you a little sense, these were 366 patients. 40% of them were negative for GAD, but out of those who were negative for GAD, only about 7 or 8% had any other antibody. So, if you've got to do an antibody, GAD alone should suffice in the largest proportion. If there is some, significant doubt in your mind and you think it's going to make an impact on the management of the patient, please remember that the diagnostic yield of the additional antibodies is not as large as you wanted it, right? And this is, again, as I said, the overall antibody positivity according to duration of diabetes. Any of the antibodies positive less than 2 years, 76%. Even at 20 years or more, it was still about 50%. So actually, sometimes say that there's no point doing an antibody test now. This patient has had disease for more than 10 years. Well, they actually do. If it's negative, you can't say much, but there's about a 50% chance of positivity even then. So again, just to give you a little sense of that. And I'm now going to sort of end up by bringing another slightly worrisome point, and that is the quality of the care that we provide. And again, remember, this is really pointing fingers at ourselves. This is not pointing fingers at anybody else. And I think one has to be, again, brutally honest with ourselves. Unless we see our own data and unless we recognize our own limitations, we will never be able to help our patients to the extent that is required. Right. So this was a study we did when we harmonized our data, as I mentioned earlier, with the search registry. And this allowed us to compare, and the comparison really brought out our differences, which are very significant. Right now, 1 second, I don't know. Okay. So if you look at baseline in search, an A1C of less than 7.5% was in 42% of people. In our registry, it was only 7%. We were 1/6 as many patients. So we clearly are not doing well. Those between 7.5 to 9% was 32% there and 10. Those were greater than 9% was 1/5 of search and nearly half of our registry. So clearly, number 1 point, we're not controlling glucose very well. And these are old data. Now with very high pumps and CGMS seen in many countries in the world, their information, their data is even better than this. The second thing that I mentioned was pump use 16% in search, 1% with us. But that's all right. Multiple daily injections, non-basal bolus. So let's talk about basal bolus. So basal bolus was 65% in search and only 1/4 in us. So 2/3 in search, 1/4 in us. So really, we are not using standards of care. The standard of care for a type 1 diabetes has to be a basal bolus regimen with a regular or short-acting analog before each major meal and a basal insulin once or twice a day. Only 1/4 of our patients were undergoing this, which is a matter of huge concern. And lastly, again, the same difference, even if you break it down from, an A1C level to A1C level. So in those with a less than 7.5% A1C, as you can see, pumps were in 45% of those in search, 12% of those in YDR. But as you go down, you can see clearly the higher the A1C, the less the pump use and the less the use of basal bolus regimen. So that is a matter of huge, huge concern that we're really not looking after our patients as much as we should. So I'm going to stop here in the interest of time to basically give you a summary that as practicing physicians and pediatricians, we need a high index of suspicion to diagnose type 1 diabetes for any sick child presenting to the emergency. It's another single prick. Please don't forget it, because the DKA burden and mortality is influenced significantly by physicians, and a delayed diagnosis and an error in diagnosis contributes to mortality. Number 3, that we should, at the earliest possible, intensify therapy to either a multiple subcutaneous insulin injection, so basal bolus, at least 3 regular, 1 basal, or even more. Wherever possible, pumps. And I'm not saying pump is a panacea, but clearly in those who can afford it, it does bring it down with appropriate counseling and monitoring. Leaving just putting a pump is not going to solve the problem. It's like saying, I'm going to buy a high-end cricket bat and suddenly I'm going to become Sachin Tendulkar. It doesn't happen like that. The third thing, which I have not touched at all today, is the need for intensive monitoring. Even with a pump, unless you're doing regular monitoring, it doesn't help. With basal bolus, unless you're doing monitoring, it doesn't help. So self-monitoring of blood glucose, critical. And therefore now the WHO, in a resolution which was passed in last year's World Health Assembly, which has been adopted by all members, said there are 5 targets for people with diabetes. And the 5th target is, the first 4 are type 2 related. The 5th target is availability and access to affordable insulin and measurement equipment or monitoring equipment for 100% of people with type 1 diabetes. So not doing proper self-monitoring of blood glucose, documenting the reasons, putting remarks, trying to correlate the sugar control with the activities, with diet, with timing, with other things is critical. And lastly, there is a critical need to ensure regular follow-up with metabolic and vascular monitoring. Regular follow-up allows us to titrate medication, and metabolic and vascular monitoring allows us to intervene early so that we can prevent and retard progression of complications of disease. I'm going to stop here. And this is a word cloud with the surnames of the patients who we lost in the Young Diabetes Clinic. This is a story of more than 40 or 50 patients. It's a terrible story that in the metropolitan city of Delhi, I can show you data of 50 dead type 1. So the prayer has to be for them, for the departed souls. And the pledge has to be that if this number is 50 today, it should never become 51. And that is, I'm sorry, a bit of an emotional message, but it's an important message, because if you've seen a 10-year-old child and they die, there's nothing worse as a treating physician. So this is our whole group of people who sort of help out in the Young Diabetes Clinic and the various projects, and I must put them on record my thanks to them so that the data which I could show you in part is because of them. And I'll stop here. Thank you so much.
Dr. Tandon, on behalf of the organizing committee and all the participants, I'm really honored to thank you for being the integral part of this educational journey. And the session today was not just informative, but it was also empowering, actually. And we all make mistakes, and definitely we should blessed to empower ourselves with knowledge of type 1 diabetes and prevent diabetic ketoacidosis and help these young children with disease to live a better life. So thank you so much. And I would invite the question and answers from all the participants, if you have question and answers, and I will request all the participants, if they have any questions regarding today's session, they can post in the QA session. And I would ask Dr. Rajiv Singla to take up the questions, and if there are any questions, we are waiting for your questions.
Yeah, I think we are waiting for the questions so far. I think I must say that that was an scintillating session as always. And I think whenever sir talk about this issue, he always ensures that we get humbled enough, but at the same time get little determination also to do little better in the future. Yeah, so I think we've got a question here. What are the average charges for gene investigations? I think it may mean two ways. I think it may be about antibodies, or it may also be a little bit about genetic investigations.
So I think before we answer the cost, I think we need to be clear, when is it essential? So in terms of antibodies, as I said, so if you look at data from more, and I'm sure Samir will take you through this in more detail when he gives his next lecture, young onset diabetes, you will have 4 broad categories. One which is obviously clearly type 1. There is no confusion about that, right? One which is obviously and clearly type 2, which is obese, parental history of type 2 diabetes, acanthosis nigricans, in a girl, PCOS. There's no problem with that. The problem comes when you have the non-lean or obese type 1, and sometimes when you're concerned about monogenic diabetes because it doesn't really fit in, right? So honestly, if the patient has to bear the burden of the investigations and there is no scope of reimbursement, the first and the last category as classical type 1 and the classical type 2, I don't know if you're going to add value to your management by doing the antibodies. In the ones in between, it would be helpful. As I mentioned, a single antibody at the moment in the form of GAD would be ideal. Now, this really varies from center to center and from lab to lab. I don't remember the exact, because what we do at AIMS is we buy the kit and we essentially do a cost price based this thing. So cost, if you're looking at the costing is not very high. But obviously, all private labs will have to have a markup because they have to take care of many other things while calculating the cost. So remember, only one, the GAD may be the only one which is required to do. For the genetic, this thing, really the time when you want to do is when you have a high index of suspicion for monogenic diabetes. So let me actually give you a small suggestion out here. Dr. Mohan at the Madras Diabetes Research Foundation in Chennai has an ICMR grant, and if you reach out to them and send them the required blood sample, they will be able to help out with the genetic test even without charge. So, again, that's a possible way of getting an investigation done, but you should have a good reason to consider why that test is required in that particular patient.
Yes, I think in the private labs, sir, one antibody testing would cost on an average around 2,000 rupees. It can vary from one lab to another lab. Just an extension of this question, sir. So what about C-peptide? Would you recommend C-peptide in all people, or how do you choose whom to be done in?
So again, I don't do C-peptide regularly, right? Again, if somebody has presented with DKA, that itself is a clear marker that they have low beta cell reserve, right? Now, where is C-peptide helping? First, C-peptide assays have changed now, so you're detecting much lower C-peptide levels. Again, C-peptide will help you differentiate when there's a little bit of confusion between obese type 1 and type 2 diabetes, in which the likelihood of a less than 1 C-peptide is much higher in those which have type 1 diabetes or undetectable. Secondly, those who are antibody positive are much more often likely to have a low C-peptide, which is less than 0.4. So again, so it basically shows that antibody positivity is related to beta cell function. And the lower the C-peptide, it appears that future progression of complications and likelihood of DKA also increases. So there is some advantage of getting that information. But again, as a routine, from a research perspective, we do it in our annual follow-ups. From a service perspective, as I said, the most important thing, utility, would be to do a C-peptide if there's doubt in one's mind as to whether this is an obese type 1 or a non-lean type 1 versus a standard type 2. And again, as I said, under 10 years of age, I would not really bring type 2 into a differential. Peripubertal and plus, I would definitely consider that.
Right. So, sir, next question is, reason for less basal bolus regime. Do most doctors prescribe mixed start?
So let me put a little clarification out here. This was the baseline performer, right? Now, baseline performer does not necessarily reflect a care by a specialist. They could have gone to the local doctor. And most doctors treat adult type 2 diabetes, and therefore their familiarity is most with pre-mixed. And that possibly reflects their familiarity rather than a conscious decision. Let me come in the defense of these doctors. But I think where we need to make people understand is that we can't manage childhood type 1 with the same insulin and regimens as we manage adult type 2. So as long as that message percolates, people, I'm sure, automatically will start improving. We also don't have protocolized versions. In terms of regimens, let me tell you one thing. I still have a whole bulk of patients, from the early 19s, and Rajiv and Samir and Saptrishi would definitely remember, who are on what we call the old-time split mix regimen, just a regular and basal in the morning and regular and basal in the evening. Maybe they weren't type 1. I don't know. In hindsight, maybe there was some difference in that. But even if you do that and add a regular in between, so it's good enough. So you need to really ensure that every meal with a significant carbohydrate intake has to have a regular insulin, and you must have a basal insulin to cover the intermeal periods. So that is an essential part.
Yeah, absolutely, sir. So, Dr. Vikas Mehrotra is asking, what is the incidence of GAD65 negative type 1 diabetes?
Right. So, at one point in time, I think this also depends on assays. At one point in time, it was felt that in the Western Hemisphere and Caucasians, 90% of people were GAD positive. And I remember a paper from it was a study which was led by Dr. Ish Bhatia, came as a letter to Diabetes Care several years ago, in which from few centers, they had I don't remember the total number of patients, but they selected patients who were within 6 months of diagnosis of type 1 diabetes, and only 50% seem to be GAD positive. I think the assays have improved over a period of time and they pick up better. So I would say easily 70 to 75% of people will have GAD positive. And if you add, as I mentioned, amongst the GAD negative, if you add another 8% or so, or 10% for IA2 and or zinc transporter, that means really overall antibody negative in our Indian setting would be less than 15%. Or
Right.
in Japan, very high prevalence of antibody negative, and therefore in the older WHO classification, type 1 had type 1A and type 1B. A was immune and therefore antibody positive. 1B was non-immune, acute fulminant, which seemed to happen in Japan, and they are antibody negative. So there is obviously some ethnicity issues, and that may also be linked to the HLA type of the individual, because DR3 is much more associated with GAD and DR4 is more associated with IA2. In the North India, DR3 is the dominant HLA allele associated with type 1 diabetes. In the South, it's a combination of 3 and 4.
Right, right. So, sir, Dr. Nikhil is asking, can we do a random blood sugar with glucometer? Patient coming with abdominal pain and vomiting. Is it reliable? Is that enough?
See, the point is, if we are saying that this pain and vomiting is because of DKA, then random is good enough, right? Because, by diagnostic criteria for DKA, it'll be a glucose of more than 250. So I'm okay, whatever. I mean, there's no point waiting for this thing. When you let's say a person is coming with pain and vomiting, and you think you need to start an IV for fluids, take a sample, get a glucose done, get a capillary done, whatever will help. You're not going to get DKA with a sugar of 120, 130, 140. It won't happen. That's when you'll have a doubt in your mind. If it is DKA and it is responsible for pain and vomiting, your sugars will be high enough, random is fine.
And I think, sir, the awareness in itself is a good enough that at least we are considering diabetes to be one of the causes for the problem that the child has. So the next question is, what is the oldest type 1 diabetes you have seen? Now, I don't know whether that means diagnosed at what age or the oldest living type 1 diabetes.
So let me answer the second part of your question, Rajiv. First, our longest duration of diabetes is a lady who's 70 years old. She got diabetes at 7. So she's lived with type 1 for 63 years. In our annual camps, we had started awarding medals for those of living with diabetes for 25 years and more. And so we have a whole lot of them. In terms of at diagnosis, I would say I don't remember offhand seeing somebody more than the 40s, but it can happen at virtually any age. But really, the peak is in the first 2 decades.
Right, right. In type 1 diabetes exchange data, I think it's the oldest person living with type 1 diabetes, 93 years old.
Yeah, they're in a different story.
Right. So, sir, the next question is, how frequently we are doing genetic testing for type 1 diabetes?
So I don't do it ever. If I'm clear in my, as you said, even the registry wise, I would perhaps do an antibody as mentioned, for if there's a doubt in my mind about whether this is, type 1 or type 2, but genetic testing in form of doing an HLA or for monogenic diabetes. So HLA we do as a research thing, and monogenic diabetes, as I said, if there is suspicion, but if I'm suspecting type 1 diabetes, I will use things like antibodies and C-peptide if there's doubt in my mind, but I won't do genetic testing.
Right, because our numbers for type 1 diabetes may be more, but per se incidence in the population is lesser. So genetic testing may make sense in countries with much higher incidence and larger resources available for them. I don't
So
know.
again, it depends on what any test is being done. A test is done to make a diagnosis and influence management, right?
Right, sir.
So I'm, as a practicing clinician, if I'm confident that I've made a diagnosis and I'm going to treat that person in a certain way,
Right.
I don't change. I mean, why impose costs to the system or to the patient?
Absolutely. Yeah. So, sir, the next, I think, couple of more questions. Can we get DK with blood sugar less than 200 milligram per deciliter who denies history of osmotic symptoms?
So, by definition, DK requires a glucose of more than 250, and it's very rare. So, there's a question which is often asked in exams or a scenario presented. So, if somebody leaves home in the morning to go to school and is fine and is in altered sensorium by lunchtime, what is more likely? Hypoglycemia or DK? It's hypoglycemia. It's very unlikely that DK will evolve in such a short period of time in the absence of any. So DK takes a little time to evolve. It's a few hours because invariably it'll be a couple of doses of insulin which are missed. There would be something. So it evolves over a longer period of time. There will be some of the other symptoms. And as I said, as per diagnostic criteria, more than 250 is really what is required.
Okay, so now maybe little more tougher questions. How can we motivate patients to come for more follow-ups?
So, in our setting, and I remember, so we have some disadvantages being, we are under-resourced setting and under-resourced patients, but we have one advantage. हम बेशर्मी के साथ टेलीफोन करके बुलाते हैं पेशेंट को, right? Because nobody can sort of accuse us that I am calling a patient because I'm going to make, a financial benefit from that visit, which is an unfortunate thing, which somebody in the private sector can be, wrongly accused of. They're not doing it to make money. They're doing it because that is standard of care. So we have now, over a period of time, it's an obsession. Appointment ले लिया जाने से पहले, appointment ले लिया. There's a name on this. There is a telephone number for there's one person who runs a telephone number, a mobile number between 9 and 5 exclusively for that clinic. That person's job is, if he has a list of appointments for the Saturday clinic, earlier in the week, he will send them WhatsApp messages, say, you have an appointment, you have an appointment. And 1 week before that, they will send another set of this thing, you have an appointment, test kara liya ki nahi kara liya. So, there's virtually a all-round obsession with this business of follow-up. As I'm saying, the very fact that instead of 400 people on follow-up, we have now 600 people on follow-up shows something. The next question about, planning to reduce mean A1C of 9, I think is a very, very important question. Personally, I feel that, there's only so much you can go with limited resources. If somebody does not have a glucometer and strips to measure, or they can measure only once in 5 days, it's not going to happen, right? They can understand. But again, we published a paper a long time ago, and it really shows that God is kind. We compared people who were not monitoring, who were doing urine glucose monitoring, and who were doing self-monitoring of blood glucose. And we showed that even with urine glucose monitoring, which is not recommended anywhere in the world now, there is some improvement in A1C, because at least the patient के दिमाग में monitoring का concept तो आ जाता है.
But I think last
As far as
question.
follow-up is concerned, pediatrician already calling patient for their routine vaccination. Basically, we also have running a vaccination clinic, and we are already calling and giving messages to our patients that they have to come for the next vaccination. And most of us are using now electronic software for prescription, and most of our EMR sends the message to the patient for the follow-up. So the standard SMS goes to the patient about the reminder for the follow-up visits. So most of the private practitioners already sending SMSs and WhatsApp messages for their patients actually.
So that is very good, and I'm sort of very happy to hear that, and I'm sure that will make an impact. I'm absolutely sure it'll make an impact. अभी तो ना भगवान भरोसे चल रहा था.
Yeah, for us also, sir, is kind of being part of your ICMR registry also does help. At least that forces us to look at our own data once in a year. We try to look at who followed up, who've not followed up, and then we try to reach out to them in some way or another. So I think the entire ecosystem does help.
So Dr. Mukesh, I think that the fact that electronic records are available allows us two things. One, for follow-up, sometimes what happens, patient aata bhi hai, lekin we don't sort of capture that information, which will get automatically captured in electronic record. And B, it allows you, the point is the effort to go through that data often doesn't happen, right? Everybody is becomes so busy. I'll tell you the real story behind the registry. When it started, there was a workshop conducted by WHO and ICMR. I proposed a registry and I thought this is going to be a type 1 diabetes registry. I never imagined that in a 0 to 25-year-old registry, 25% of people will have type 2 diabetes.
True.
I had thought this is a type 1 registry. You see, just the very fact that we have never looked at our own data so carefully that we write. So, capturing information, which fortunately is happening as you just informed us, using EMRs is one part of the journey. Second part of the journey is actually looking at that information. बड़ी उसमें ना कठोर सत्य पता लगता है उसको देख के.
Yes, sir. I think 2 questions are left, sir. Sir, what about thyroid profile?
So we do TSH TPO annually. It's perhaps not required annually, but we are obsessive, so we do it annually. And so that is done. Definitely has to be done.
So, sir, next question is, I have a 3-year-old girl diagnosed as DK at 1 year of age. Her HbA1c has always been normal even at time of DK and when sugar profile is markedly deranged.
So that's an interesting thing. The only sometimes what happens is, and I'm not sure if that's the case, and I'm sure you already thought about is that there is there a technical issue with the A1C because of an underlying hemoglobinopathy, right? There are at least in North India, thalassemia traits can happen. I still remember not a type 1 diabetes. I was sitting and struggling with a patient of type 2 diabetes, Punjabi. And I was talking to the resident कि हो सकता है hemoglobinopathy हो, इसका hemoglobin में कुछ problem हो, etc. Patient said जी हमारा रावलपिंडी वाला hemoglobin है. But basically, so there was a recognition that there was a variant. They were Punjabi migrants from the time of independence. Again, patients who are coming from, there you are, Nishu is saying we are from sickle cell area. So again, those are often an issue. So if the glucose is high, you have to accept that. What you are saying is that you unfortunately cannot use A1C therefore for a follow-up, and that adds to your problem. So CGMs would be required if at all. This also happens in the northeastern part of the country when HbE thalassemia is a common. So there are pockets where the prevalence of hemoglobinopathy is so high that that A1C is useless. And thank you for pointing that out. It's an important because North में thalassemia thal trait is very high. Punjabiyon में ज़्यादा होती है. So again, we have to be careful.
Yeah, in a large study from Metropolis, I remember, so they published their data on this thing. So there was almost prevalence of around 7 to 8% of people who overall in their, like, obviously it was not a population based study, but there are these large people who've got hemoglobinopathies, and then we know that HbA1c may not be truly reflective of their glycemic status. So I think that was all. We've answered all the questions, and my sincere
Dr.
thanks
Rajiv,
to.
there is a question from Dr. Deep in chat.
Okay.
The question is,
should we do a BMD assessment in type 1 diabetes?
If at all we should do, if we should do, what is the good time, or should we not do?
So Deep, your judgment on this is as good as mine. We've done all this as part of care. Honestly, I don't remember if the new recommendations specifically say that. So you might be able to guide us better on that, but I don't routinely do it. The issue is that if there is additional issues like celiac, then perhaps I think it does make sense, because it'll also be a guide to you in terms of how well you're managing the celiac component also, which will definitely impact on BMD. But honestly, I don't have a complete answer to your question.
Thank you, sir. Thank you, sir.
So,
Yeah, I think yeah, please, Dr. Mukesh.
Dr. Rajiv, yeah, you can.
No, yeah, I was just saying thank you to Dr. Nikhil sir for this an excellent session today, and over to you.
Dr. Nikhil, आज का जो सेशन था उसने रियली स्ट्रॉन्ग फाउंडेशन बना दी है आगे के सेशंस के लिए, और आई होप कि आज बहुत पीपल हैव मस्ट एम्पावर्ड विद द इंफॉर्मेशन, एंड we hope to see a very successful this diabetic education program, type 1 diabetic education program. And my special thanks to Dr. Rajiv Singla for coordinating this education program, and he has been instrumental in designing it, coordinating it, and it's really inspiring to see his dedication towards type 1 diabetes. And I am also very thankful to Dr. Vipul Jain for facilitating many educational initiatives like this. The IAP Delhi is running hematology educational program, dermatology education program, now this type 1 diabetic education program, and Dr. Vipul Jain is instrumental in this. He is actually the background work all he's doing, and he's really inspirational to us, and I'm really thankful to both Dr. Rajiv Singla and Dr. Vipul Jain, and thankful for their time and effort they have put for this program. And last, I'm also very thankful to all the participants who have attended today's session, because it is for them that we are doing this program. Over to you, Dr. Rajiv and Dr. Vipul, if you want to say something.
Thank you, Mukesh. I think let us meet again next Sunday, 11 a.m. with the next session. Anything? Dr. Saptashi, would you like to comment anything?
I think thanks to Dr. Tandon, thanks to Dr. Mukesh, Dr. Vipul, and obviously a big thanks to Dr. Rajiv Singla for putting this all together. And thanks to all the participants on a Sunday morning. We get close to 200 attendees listening to Dr. Tandon. It was really worth it. And we have learned so much in our DM days from Sir, and we still keep on learning from him. So it's we are really honored that he started the session in a huge way, and thanks to all the speed members who have been also part of this journey. And I think we need to also thank USV, who has helped us stitch together and put all the logistics in place. Thank you once again. Hope to see you next week.
Thank you.
Great. Thank you.
Thank you, everyone.